So I've known you from our Endo Microsurgery Facebook page. All the amazing posts you put on that and on your Instagram account. So I was really excited to try and get you on to share your knowledge and your passion for endo microsurgery. So you don't need any introduction, but you are a professor of endo microsurgery in Medellin, Colombia. And you have a real kind of world expert in this topic. So what the aim of this webinar to do really is to try and encourage dentists to be at least aware of the advances that have been made in endo microsurgery, to consider adding it onto your kind of treatment plan options, and to work with either yourself to make sure that you kind of can upskill and to consider adding it, or to work with your local endodontist surgeons to incorporate it into treatment planning. So the way we're going to try and work this webinar is we'll just do some case selections first, and then Paula will look more into the actual technical aspects of the microsurgery and how to do it step by step.
Thank you, Daniel, for the invitation. For me, it's a big honor to be here sharing with you cases and this passion about endodontic microsurgery. Thank you.
Yeah, my pleasure. So let's start. So basically, I'm a specialist as well. So I work exclusively in an endodontic practice, but I work very closely with prosthodontists, with periodontists, and with general dentists as well. And one of the biggest kind of issues that we have is kind of treatment planning. And it's to make sure that we're giving patients the correct options and allowing them to make a decision then based on what their requirements are. So now it's got more difficult than ever to kind of make decisions, and it's there's so many different options available. Now there's whole extremes of cases where there's dentists who just do implants, and it's like all they want to do is implants. There's other extremes of dentists who just do endo and all they want to do is endo. But it's really important to have good knowledge of all the kind of options that are available and to be able to advise patients accordingly. Unfortunately, there is a perception that endodontic treatment isn't successful. And this is a case where a young girl was in her 20s, she fell and she has an incisal enamel dentine fracture here in her upper right one. And the treatment went well. You could have a root canal treatment, but that's not likely to work. And then you need to take the tooth out and you need to do an implant. So maybe you're better to do an implant straight away. And as an endodontist, this kind of thinking is really kind of upsetting to us because we know how successful root canal treatment is. And we know that the likelihood if you do technically good root canal treatment, likelihood of success. Even in a small percentage of cases where root canal doesn't work, we have the option of doing endo microsurgery on top of that. And again, for that, we've got extremely high success rates. Now, the problems if you do skip all those steps and you jump into implant treatment very early, especially on young patients, is that aesthetically, it's always more difficult to get a really nice aesthetic result with prosthetic replacements rather than the natural tooth itself. So if you look at this case here, look bone heights that are there. The bone has been held by the periodontal ligament and the tooth itself. So once the tooth is removed, you're going to start losing some bone. So you can see because this tooth has been extracted, the bone crest has gone from here and it's dropped significantly around the implant. Then aesthetically as well, when the bone drops, you start to lose some of the papilla height as well around the teeth. So it's really important, especially for aesthetic cases, that if you can keep the natural tooth, it's going to be a benefit to the patient in the long term. So endo in general has improved massively over the last, even since I qualified as a specialist in 2008, all my protocols have changed massively since then. Now we have access to control memory files. We can do super conservative access cavities where we can preserve lots of tooth structure without compromising on our endodontic objectives. We can save pericervical dentin, and we can still get reasonable apical shapes to make sure that our cleaning and disinfection protocols are successful. Our obturation techniques have changed as well, where we can let me just go back here. So we can inject sealers into the canals. The flow rates are really, really good. So we don't have to do big preps to be able to get heated units deep down into it. So we can be a lot more conservative, preserve a lot more tooth structure. And the more tooth structure that we can preserve, the more likely that the teeth are going to last long term. So in my practice, when we see good root canal treatments, the biggest cause of failure is root fractures. So if we can preserve a lot more of the pericervical dentine, hopefully we can preserve the long-term prognosis of the teeth, because we know that when we get to land, when we've used good disinfection protocol, the likelihood of pure endo failure is quite low. So this is one of the first cases that got me really interested in endo microsurgery. And this is a case we have lots of discussion with because there's so many treatment plans. This lady was a journalist and she'd been to 10 different dentists. So she had so many treatment plans and every single one of them were different. And what really intrigued me about this case is why that everybody has the exact same information that starts. It's the exact same patients, her finances are the same for everybody, but yet there's so many different protocols and suggestions how to deal with the issue. So her main concern was that she's got pain and swelling on the upper right 3. She said 9 courses of antibiotics to deal with this. So, I mean, the antibiotics will never get rid of the source of the infection. So she was fed up at this stage and just really wanted to get a definitive answer to her problems. So in these cases, there's so many options that we do. So some of the treatment plans included removing, so she had lost her 2 central and lateral incisors when she was 16. This was the second bridge that was placed. She was in her 30s now. But prosthetically, all the margins are nice. It's well-fitting. She's happy with the aesthetics that are present. And the treatment plans ranged from extracting 4-3-4-3-4 and doing implants, all the way to removing the teeth and doing a denture, to dismantling all the teeth, removing all the posts, redoing all the endos, replacing the posts, doing new bridges. So there's a whole range of options that was presented to the patient. And it can be really difficult treatment planning these cases because there's so many factors that we need to take into consideration. This is another case where aesthetics were critical for this particular patient. So the most important thing for this patient was just the aesthetic look of the teeth. So the dentist had spent a long time trying to get the aesthetics right. This was the initial situation where basically there wasn't a lot of tooth structure above. So, I mean, lots of dentists will look at that and go, absolutely, it needs to be extracted and an immediate implant placed. And in cases like that, I would totally agree. That's a fair treatment planning decision to make in this. In this case, the dentist who actually normally does a lot of implants, on discussion with the patient, was worried that he wouldn't be able to match the patient's aesthetic concerns. And the main reason he was worried about that is just the proximity of the lateral incisor and the central incisor. And like the previous case, he was worried if he extracted this tooth that he was going to lose a lot of bone in this region between the central and lateral incisor. And therefore was worried about how the papilla here would look and the patient's concern. So this patient on presentation starts talking about stippling of the papilla. So he's a very, very, very conscious patient. So in the end, what they did was they placed a post, they accepted the root canal treatment that was there, they did a crown lengthening, and they got a beautiful aesthetic result. However, for the case, now the patient has pain and swelling on the apical part of the upper left 1. So now that leaves us in a dilemma. We've got a really large post. We've got a beautiful crown that's just been placed. We've got an apical lesion on the upper left 1. So how do we deal with this? So first thing for these cases that's an absolute must is a cone beam CT scan. I've worked with a lot of different scanners over time, and it's really important to have a cone beam CT scan where you can actually get the information that you need. So this is an example of the scanners we use. So we can see that there's apical pathology here associated with the upper left 1. There's a large post that's been placed. It's pretty much centered in the canal. We can see where the previous crown lengthening has been done. And we can see basically there's 3 or 4 millimeters of GP in the canal. So we have some room, and we can see where the buccal bone has been lost. Now, things that are concerned in treatment planning. So if we remove this tooth, how much of the buccal bone are we going to lose? We'll be able to place the implant here palatally, so it should be fine. But just aesthetically, are we going to be able to get the same aesthetic result as we can by keeping the natural tooth? So the way we plan our flap, we use cone beam CT to guide our flap design. So we're looking, where is the bone? How are we going to access the lesion? And we can see all this before we touch the patient. This is another case where this patient is an actor, and as part of his kind of contractual obligations, his smile had to look the exact same from the start to the finish of filming. And in this case, he has pain and swelling on his upper right one. He had all his cosmetic work done in Los Angeles, and this is what we're faced with now. So he's got pain and swelling on the upper right one. We've got a big, long implant on the upper left one. So again, in these cases, if we lose the tooth in the upper right one, we're definitely going to lose some bone between the teeth. And then that's really going to cause a challenge aesthetically, keeping the soft tissue papilla between two central incisors. Now, the other issue we have here is when we look at our periapical radiograph, there's no obvious pathology associated with the upper right one. So now we have to try and identify what is the cause of failure, what are the treatment options that we're going to offer to the patient. So again, you must have a cone beam CT scan. In this case, we can see that there's a big buccal perforation of the bone. This is exactly where the patient is feeling the pain. This is where the tooth is swollen. We can see there's a large empty canal space here, and there's potentially a lateral canal that's exiting where the pathology is formed. So that really kind of helps us now to identify some treatment strategies and what we're going to do to try and offer to the patient. So the key again in that case is to keep the aesthetics and to make sure that it looks the same when he leaves. So he's got a high smile line. He's showing the gingival margin. So if we decide to extract the tooth, how are we going to make sure that we keep the papilla height? How are we going to make sure we keep the gingival contour here? If we decide to dismantle the tooth, it's got a very large post that's potentially going to weaken the tooth. We're going to try and remove that. Or if we do a surgical approach, how are we going to manage the soft tissues so that aesthetically the smile is going to look the same afterwards? So these are challenging cases. Here's another case where we have very large apical radiolucency associated with the upper left one. This patient has been taking oral bisphosphonates, and she's done a lot of reading about potential necrosis following any surgery with bisphosphonates. So in this case, then we have to look at what the options are. So obviously, if we extract the tooth, that's got the biggest risk of necrosis. If we dismantle the tooth, we have to take the crown off. We have to use ultrasonic vibration to remove that post. We have to try and remove the sectional silver point that's apically. And then we have to try and see, are we going to be able to remove the source of the infection that we can get that large lesion to heal? The other problem in these cases is that she has a restoration on the upper left too. There's evidence of pulp canal obliteration here on this tooth as well. So our vitality tests were negative on this tooth, but is the source of this large lesion from the upper left 2 that's obliterated, or is it from the upper left 1? So how do we figure out these things when we're treatment planning? So again, always cone beam CT scan, like that's a must in my practice for all potential microsurgery cases. I want to be able to see where the buccal bone is. I want to be able to see the extent of the lesion. I want to see if it's perforated palatally or if it's perforated into the nose. I want to try and see where it's centered. And then that just helps us make decisions on what to do. Again, this lady's had aesthetic treatment that was done well over 20 years ago. So while it doesn't look fantastic now, she had no real concerns about the actual aesthetic appearance of the teeth. Perforations can happen. It's like the more endo you do, it's like there's always a chance that you perforate, and especially lower incisors teeth, they can be really, really narrow. As this was a case that was done by a specialist colleague. So even dentists who do endo day in, day out can perforate. And often what can happen is it's like you try and follow, if you're looking at the adjacent teeth when you're doing your access, and if you follow the long axis adjacent teeth, you can just go slightly off course. So here, after the perforation, we've got a large lesion that's affecting multiple teeth. We've got technically a good root canal done. There's been an internal repair of the actual perforation that's there. There's negative response to the adjacent teeth on our electric pulp testers and our sensitivity tests. So again, it makes the decision-making challenging. Is the source of the infection just on the lower left one, or are there multiple teeth involved in this lesion? So in my practice, I always try and do a really, really very conservative approach. We have a 9mm pocket here associated with where the perforation is buccally, and that goes right down to the apex. So the questions here are, do we have a root fracture? Do we have an endodontic infection apically that's just draining through the periodontal pocket, or is the perforation area that's affected and it's draining through the pocket? So there's loads of questions, and the decision-making can be challenging. Lots of dentists will look at a case like this and just say, extract the tooth and do a resin bonded bridge. That should be a really predictable way of doing it. The other options are, I don't think redoing the root canal again is going to be effective because it's been already done to a really high standard. And then the last option is to do an endodontic microsurgical investigation stroke treatment. So we'll remove all the apical tissue, we'll remove 2 to 3 millimeters, and we'll repair the perforation all in one go. Okay, now this always kind of concerns me when you see a lesion that comes all the way right up corona. Now, in this case, once you have, there's a little bit of coronal bone all the way around, but you've got a short, wide post and a very narrow tooth. So I always encourage all our dentists to try and not cut away tooth to place posts. So try and maintain as much tooth structure as you possibly can. But when we have big fat posts in small narrow teeth, that is not a good recipe for long-term success. Again, when we have teeth, this was referred to me by a really good implant dentist who the patient just refused to accept the risks that were explained to her with implant dentistry, so it was sent to us. So the first thing we look here is that the coronal seal is suboptimal. So for any kind of endodontic treatment, we're all aware that coronal seal is essential for long-term kind of failure, for long-term success of endodontic treatment. So the kind of criteria that we look at is the tooth restorable, or does it have a good existing restoration in place? What's the periodontal condition around the tooth? And then third, what's the endodontic prognosis? So generally the endoprognosis, unless the tooth is cracked, we can fix the vast majority of endodontic issues. So then it comes down to periodontal and restorative. The restorative and the periprognosis is good, we can be really confident that we will have good success. This tooth already has had a surgical procedure before. There was no apical seal put on. You can still see the silver point that's in place. You can see a little dimple here where they've had some kind of retro prep without any kind of material that's sealed. But the main issue to start off with is we need to remove the crown and get a coronal seal. Then we can assess the post. If the post looks like it's sealed well, then we can potentially accept that. If the post is leaking, then we know we have to remove the post as well. But the call is structurally this a good tooth to try and maintain, or are we better off to do another option? Pulp canal obliteration. So this again, this tooth's had an attempted root canal treatment done. No canal was found. And then a surgical approach was done where, again, a little dimple was made on the side of the tooth. Now, invariably, when we go into cases like this, where the old retro prep and filling was placed, doesn't normally correlate with exactly where the apical path of exit is. So that's why it's so important. And Paula's going to talk about the technological advances and why a lot of previous surgery that's been done, there was a lot of difficulties in being able to identify the real precise anatomy and to be able to execute the treatment well. However, having said that, this is a tooth that lasted like 15 years in this condition. So it's obviously had pathology for a while, but the tooth is still present. So the main concern for this patient was they weren't aware of the large endodontic lesion. The main issue that they had was an aesthetic concern. So as always, when we're kind of treatment planning, it's not things that we want to try and fix. We need to listen to the patient's concerns, explain to them the biological condition that's there, and try and offer options that are going to address their concerns. So in a case like this, do we try? Obviously, one, we have to get a cone beam CT. Again, that's mandatory for these kind of cases. Identify where the cause of failure is, identify where the canal is, and then decide, are we going to do an orthograde approach or a surgical approach? Now, in a case like this, if this tooth is going to need bleaching, do we try and do an orthograde approach, or if it's complete canal obliteration, just do we do an access cavity and try and do some internal external bleaching and deal with the endodontic issue separately? So again, so many different options in all these cases. Then we get referred cases where the treatment's already been completed by an endodontist to technically really good standards, but there's still pathology. So these are some of the rare cases we get where good endo has ultimately failed. So in these cases, structurally, the teeth are intact. We're not worried about durability. Periodontal condition is fine. These are pure endo failures. So again, have a cone beam CT essential beforehand. So look at this tooth. Loss of buccal bone all the way up to the base of the nose, perforation into the base of the nose, and there's some perforation palatally as well. So if we extract this tooth, we're going to lose this buccal bone. And then all of a sudden, it's so much more difficult to try and restore this in an aesthetic way. Now you can see the tooth has gingival inflammation from composite veneers that were poorly contoured. The patient has actually really good hygiene, but it's like restorative issues that have caused the inflammation around these teeth. The tooth has been extruded, and our original treatment plan was actually to try and get that tooth back into position without actually addressing the underlying cause of the issue. So in these cases, if we can use endo microsurgery to, first of all, we need to get the gingiva healthy. And then after we've got the gingiva healthy, we can use endo microsurgery to regrow natural bone all around these roots. So we can get an infill of real autogenous bone without need for grafting, without the need for biomaterials. We can use the patient's own blood clot, get a stable clot, plus or minus grafting, depending on, or a membrane, depending on the actual case, and we can get real bone to grow back in. So even in cases where teeth are really borderline restorable, and we know that the long-term plan is going to be implants, we have a lot of cases now where we're literally just doing the microsurgery to get infill of bone in this whole area, and then the teeth have been removed and an implant has been placed later. So it can work hand in hand to make the implant treatment a lot more predictable. So again, this is a case where the tooth's been treated by an implant or by an endodontist. For a canine, I'd want to get a cone beam CT scan just in case there's a second canal that's present. But look at that she's already had an implant in the upper three. So there's kind of a myth that implants are successful 96, 97% of the times. But we see the practice I work in London used to be one of the biggest implant practices in London. And now they've cut down on the number of implants they've done massively by having lots of focus on perio, endo, and they were already brilliant restorative dentists. So the whole focus of the practice has changed to preventative regimes, because over time they've just seen so many problems with implants that technically they need to be planned really, really well. Biologically, they are brilliant, but also there can be problems with it as well. And this poor lady was having a lot of problems with the implants that she had placed in the upper right 3 region. And she was really trying to avoid that same situation happening on her lower canine. So when we look at the lower canine, structurally, the tooth is absolutely fine. Periodontally, it's absolutely fine. So it's just, again, endodontic failure. Again, we have the situation where the lesion is affecting multiple teeth. There's kind of uncertain sensitivity tests from both of these lateral incisors in this. But again, we try and focus just on the main source of infection. And we tend to have really, really good outcomes with that. This is upper right 6. So this lady was about to go to climb Mount Everest in 4 days, and she presented with buccal swelling and pain on her upper right 6. So we know that she's got a missed MB2 canal in this case. So the options are: we extract the tooth where we're guaranteed success. We do a targeted approach where we do a small little keyhole in the crown, we remove the GP, we find the MB2, we clean it, we disinfect it, seal it up, or we do a microsurgical procedure. So in a kind of textbook way, the best way is to kind of retreat it and optimize and try and fill all the canals from an orthograde approach in the first instance and have microsurgery as a backup. But occasionally patients will say, I really don't want to have, I want to optimize my chances of success now before I go away. I don't want to be on Mount Everest and have pain and swelling on that. So in these cases, we will sometimes do a surgical approach because we know by removing annihilation tissue, we'll know by removing the top 3 millimeters of the tooth, which has the most complex anatomy. We know that the likelihood of flare-ups or problems while the patient's away are going to be minimized. Whereas if we redo the root canal, we know apically how complex the anatomy is, and there may be a flare-up in 3 to 4 days' time, or there may be an issue that causes her a significant problem when she's away. This is another case where we've had a brand new crown placed 6 months previously. We can see that there's been a perforation, a strip perforation. It hasn't quite followed around the curve. We have a large lesion here that's right up to the sinus. So again, in these cases, do we go back into these cases, remove all the gutta percha, try and get back into the original canal, try and seal it up? We know that there's a missed MB2 canal in this case as well. So the patient's already spent a significant amount of money on this tooth. So do we cut our losses and extract the tooth, but then they're going to spend a lot more if they want to replace the tooth with an implant? Or do we do a surgical approach, or we do a retreatment? So it can be quite difficult in our treatment planning to figure out what's the best way to go. But it's important that we have all the options, that we're able to explain to the patient the pros and cons of each of them. We're explain the time and the finance that's involved, and then we can come to a collective decision together. And then just the last kind of things in case selection is that, remember, all like radiolucencies that are present, they're not always odontogenic. So sometimes we have lesions, like in this case, that both of the teeth either side were both testing positive to vitality tests. So if they're both vital, it's unlikely that this lesion is odontogenic in nature. So we just need to be aware of that, and that we're aware of the other differential diagnoses for radiolucencies in the maxilla and the mandible. And this is actually the last one. So we have fractured instrument removal. So we have a whole range of options and skill levels included on these. We've seen all of Yossi's cases that he posts. So I mean, I'm sure in his hands, this straight away would be a retreatment retrieval attempt around the curve. We see lots of dentists who can bypass these instruments successfully. But again, we need to have a cone beam CT scan. So we can see in this case that there's a separate MB2 and an MB3 in this case, actually. So sometimes you don't actually physically need to remove the instrument. So we can clean out all the anatomy that's been missed. And a lot of times we can achieve success in that. Or do we go straight in, do a surgical approach? Do we extract the tooth? In this case, it's even more complex because we have a crown. The margins here are not perfect. They're not terrible. It's like, do we need to dismantle the crown to make sure that there's no leakage underneath it? Or do we extract the tooth? So there's so many variables involved in all these decision makings that we really need to have an open mind and to be able to go through all the options with the patients specifically to be able to give them a good guide on how to do it. So this is, Paula's going to really talk about this in her part, but this is the past, hopefully, where there's been very kind of poor selection, coronal leakage. It's like poorly placed retrograde fillings, retrograde fillings placed on teeth that didn't have any conventional endo. We have examples of where there's poor root resection. So no wonder that the perception of dentists is that apical surgery's got a poor success rate. And what has changed? Basically, every single part of our treatment has changed. The way we diagnose it, the way we handle soft tissues, the magnification that we have, the way we do resections, the way we do retropreps, the materials we use, and suturing. So every single part of the treatment has changed. And really, what I'm hoping that our webinar today will do is just to help get more dentists involved in endomicrosurgery, to consider this as part of your treatment planning strategy, and to work with colleagues to really make this option more available for patients. So I'm going to hand over to Paula now, who's going to go through some of the technical aspects of microsurgery, and she has some beautiful cases that she's going to share with you.
Daniel, you just mentioned the main indications of endodontic microsurgery. And well, I will talk about modern endodontic microsurgery, with, as you say,
Yes.
some technical aspects. First of all, why to consider modern endodontic microsurgery? Because it works. In this research published by Dr. Kim and his work, in the first part, they compare the positive outcome of traditional endodontic surgery to endodontic microsurgery. And look at the difference, 59% versus 94%. I think this is a huge difference. So we need to consider the endodontic microsurgery as an option for our patient, an option to save natural teeth. And now we perform modern endodontic microsurgery with a lot of technological aids. And I think this is the result of the evolution of technology applied to endodontic microsurgery. And the main milestones we had in endodontic microsurgery, I think, is the microscope, the introduction of microscope in endodontics and in surgery, obviously, with micro instruments and ultrasonic devices. Also, the development of MTA, that it was the beginning of new materials. But with the introduction of ultrasonic devices, of micro instruments, microscopes, we had the opportunity to really treat the cause of the problem. Remember, the cause of the problem is in the tooth, is inside the tooth. Many of the times is inside the canal. The cause of the problem is bacteria. So we need to remove bacteria. That's why we need to perform the apicoectomy. And then we need to prepare the apical cavity in filling the apical cavity. Before, we only had bars to perform that cavity, and it was very difficult to stay centered inside the canal. Now, with micro instruments, with ultrasonic tips, we can really stay inside the canal, really clean and shape the apical part of the canal. But why so important? Daniel just mentioned something about the sealing, the coronal sealing, but the coronal sealing is as important as the apical sealing, as the apical filling. In this study, we published this study some years ago. We evaluate 171 teeth that had endodontic surgery, and we had follows over 1 to 16 years of those teeth. And we found the prognostic factors, the main prognostic factors of these surgeries was the apical filling and coronal filling. So it's not only the apicoectomy, it's not only to remove the lesion, we need to treat the tooth. And now we have a lot of tools, a lot of technological aids that have increased the success of endodontic microsurgery. In the second part of Dr. Kim's study, they conclude that the probability for success for endodontic microsurgery when it uses a high magnification device like microscope or endoscope is significantly greater than when we don't use any magnification device. It's simple. We can only treat what we can see. It's difficult. We need to treat the apical third of the tooth, and sometimes we need to see very small details. We need to look for omitted canals, for isthmuses, cracks, and without correct magnification and with correct illumination of the area, sometimes it will be absolutely impossible. So I think the use of microscope in these surgeries is not under discussion. The second technological aid is the ultrasound. Ultrasound not only for preparing the apical cavity, but for performing osteotomy. Basically, piezo surgery refers to ultrasound. And I try to briefly explain you how it works. In the handpiece, we will find some ceramic rings. Those are some ceramic rings. And those ceramic rings change dimensionally when electric charge is applied. That change generates vibrations, and that vibrations is transferred to the ultrasonic tip. That vibrations over the hard tissue can cut hard tissue, not only bone, but tooth. So in endodontic microsurgery, we can use this technology to cut hard tissue, to cut bone, to perform the apicoectomy, and for soft tissue displacement. Some advantages of this technology: we can cut in a more precise and safe way. It cuts hard tissue without damaging soft tissue. And for me, this is the main advantage of this technology. Is very, very, very safe to cut near to some anatomical structures like maxillary sinus or mental nerve. Also, we will have wide visual access. I will show you cases explaining all of these aspects. Look at this research. In this research, they use mice tongues, and they wanted to measure the time needed to cut the soft tissue, the tongue tissue, with carbide bars, fissure bars, diamond bars, and piezosurgical saws. At the end, they found that with carbide bars, 1 second and 21.21 seconds was needed to cut the tongue. With fissure bars, 1.03 seconds. With diamond, almost 8 seconds. But with piezosurgical saws, they didn't saw cut after 20 seconds in contact with the soft tissue. So we can touch the soft tissue. We can be relaxed when touching the soft tissue. But it's very important to take this into account. Please keep in mind, they are safer when cutting bone close to the nerves and maxillary sinus. But piezosurgical works in a range between 30 to 60 kilohertz. And when they are working over 50 kilohertz, they can cut soft tissue. So keep it in mind when you are cutting very close to the maxillary sinus or the mental nerve, for example. Please try to work in the lower frequency of the equipment. Look at this first case. The patient was referred to perform the endodontic treatment of this second upper molar. I didn't find the MB2 canal. I saw in the CBCT, I saw the MB2 canal. It was just right here. But clinically, I couldn't. So I decided to finish the endodontic treatment and follow the patient. After 2 years, I saw again the patient, and she had infection. She had signs of infection. Look at the maxillary sinus. Look at the mucositis the patient had developed related to the apical lesion in the palatal side of the mesiobuccal root. Look at the axial view of the 2 years follow-up CBCT. Here you can see the lesion and how close to the maxillary sinus it was. Once again, we need to evaluate the possibilities. The root canal retreatment was one possibility, the extraction, and the endodontic microsurgery. About the retreatment, well, I had a search for the MB2 and I haven't found it, so I decided to go for the next step, which is the microsurgery. like to highlight from this case the cutting ability of the piezosurgery devices. Look how thin is the cut on the bone. Then, after removing the cortical bone, we will have enough visual access to cut very precisely the apex of the buccal roots.
Beg him, please sing him. Come by the things unsaid. Shoot an apple off my head and a trouble that can't be named. Tigers waiting to be tamed, singing.
Then, and after removing the buccal apex, look at the image. This is the membrane, the sinus membrane. We only had a small perforation of the membrane, and this perforation was produced while removing the apex. But what I want to show you is, look, the cut was made over this side, and this side. The instrument was in touch with the membrane over these sides, and we didn't have perforation with the ultrasonic device, with the piezosurgery saw.
That's beautiful.
Yeah, I think this is the proof of it works. It really works. We will have better bone healing than with rotating instruments. There are some articles in the literature that have shown that there are more favorable osseous repair and remodeling when cutting with ultrasonic than when with cutting with low speed or high speed bars. A lot of studies have compared the bone results, the bone healing, when cutting with both kind of instruments, and most of them conclude that we will have better early stage of healing, better integrity of the bone. We will have higher BMP's production. We will be faster healing of the bone, better control of the inflammatory process, better bone remodeling, better microcirculation. I mean, all the results are better for the piezosurgery devices comparing to rotating devices. Look at this case. I think in cases like this, there are not much options. The only option here for me is the endodontic microsurgery. We had a full crown restoration, a well-adapted full crown restoration, which is important. The post, a cast post, and the apical lesion related with the mesial root. And look at the anatomy. It's not easy to find the apical tear of the canals, of the mesial canals. So the only option here for me is the endodontic microsurgery. After elevating the flap and exposing the bone, we perform a cortical window technique. A cortical window technique is not new. It was described many years ago, but I think it had gained attention in endodontic microsurgery over the last years because of the introduction of this technology of the ultrasonic devices in our field. So what we do is cutting the window, then remove the window. We maintain the bone in saline during the surgery, and at the end, we can put the bone back. Let's see. some advantages of this technique. We can reconstruct immediately the bone defect. This is natural bone. This is autologous bone. So it will act as an autograft, which is the gold standard when talking about grafting materials in endodontic microsurgery. Also, we can have a wide visual access because if you need, you can do a big window. You can do it for one or for two roots in cases like lower molars. It's very common to use this technique for lower molars. I think it's easy and we can have at the end a predictable healing of the bone. This is the case 6 months after surgery. We have complete healing of the area.
Amazing.
This is another case we had in this case, a root resorption caused by the impacted canine. And after the orthodontic treatment, we had not only the root resorption, but necrosis of this pulp. So I performed the endodontic treatment, but I could only go until the resorption area, and we didn't obtain healing of the infection. So the next step was the endodontic surgery. During the surgery, we had two options. One was removing the apical tear, and the other one was treating the apical tear. I decided to treat the apical tear through the endodontic access. This is the clinical aspect. We had an apicomarginal defect in the mesial area, the cortical bone and small cortical bone. Some years ago, we used to lose this bone because we had to perform the osteotomy with bars. Performing this technique with bar is not well recommended. Then I found the canal, the apical tear of the canal. And after filling the canal, I just put PRF and the bone back.
Can you explain a little bit about the PRF process as well, Paula?
Okay, what we obtain with the PRF is platelets of the patient, activated platelets of the patient. It's easy to obtain. We do it in the same moment of the surgery. It takes you, I don't know, like 15 minutes to obtain the PRF. And what the researchers have found is we have a better healing, faster healing, and the post-surgical, the immediate post-surgical days are better for the patients. So nowadays I try to use PRF in most of the cases. This is the result of this case. Look at the post-surgical X-ray. And 1 year after surgery, look at the axial view. We can even note where the bone was cut. The integration of the buccal bone was perfect. The buccal bone was already healed without any gap. And also the medullary bone was completely healed 1 year after surgery.
Nice.
About wide visual access, that's important because when we use the handpiece, well, we usually use an angulated handpiece, but the head of the handpiece sometimes is make us difficult to see very well the surgical field. Look at this case. I posted this case yesterday in Facebook group. It's beautiful because we had a small bone access. So that small bone access didn't allow me to enter inside the canal. And I had to perform a small cut in the bone to allow the instruments to enter in the canal.
Yeah, I think it's really important to have the ultrasonic tip free, because especially when you start to do microsurgery and you're not that experienced, I think you underestimate how to get the proper access along the long axis of the tooth. So very often when we're kind of redoing microsurgeries, we can see that it's gone too far lingually or too far palatally, whereas actually you need to make sure that you've got the room to get your ultrasonic tip in so you can actually follow the GP, stay in the center of the canal, and it's often a little bit more buccally than you think.
Yeah, yeah. And there is a tip. If there is good aperture inside the canal, you have to see good aperture when cutting with the ultrasonic tip.
Yeah.
If you don't see good aperture, you are not inside the canal. You are cutting
Exactly.
them. Yeah.
Yeah. So, and a lot of that then is just the feel. So you're trying to, it's like the same way you're doing your orthograde endo, you're trying to have the tactile feedback. It's the exact same for surgery too. It should feel very soft as you're going through the GP without any resistance.
And we can do a small cutting of the bone. We don't need to cut much bone. We don't need big osteotomies. I think it's a big advantage of these kind of instruments.
Absolutely. Well, I think as well with your cone beam CT planning, it's like what we talked about. You plan your flap from the cone beam CT scan as well. It's also you plan your osteotomy from the scan too. So you don't even have to, when you actually go to execute the surgery, you know every single step what you're going to do. You can visualize how big your osteotomy needs to be. You know exactly where the roots are, and it's a completely different procedure to how it used to be when we used to literally lift up flaps and kind of investigate. It was now we know what we're looking for before we start.
You have mentioned something very interesting. You said something like the soft tissue needs to be the same than before surgery or better, something like that. But I'm absolutely agree. After the surgery, the patient, the soft tissue needs to be the same or better.
Absolutely.
Yeah.
Because I think it's I mean for that's where we see where a lot of people, when they try to do surgery but they don't have the soft tissue skills. I think before you do microsurgery, it's really important to learn how to suture well, learn how to cut flaps cleanly, learn how to raise the tissue gently. And it's a very simple process once you've kind of practiced it, but it's crucial before you start getting into the intricacies of isthmus cleaning and all the kind of grafting and PRF, all the kind of complex stuff. You really need to master the basics of surgery first.
Yeah, and I think it's one of the most beautiful parts of the surgery, the soft tissue management.
Yeah.
Well, less noise with ultrasonic devices. This is another advantage, maybe not for us, but for the patients. You know how the patients feel with the hand pieces. Look at this comparison. Let's see the noise of the surgical hand piece compared to the noise of the piezo surgery saw. Now, just imagine that noise and vibration in your mouth.
Yeah, absolutely. And it's like most patients are afraid of the noise. It's like the anesthesia is so good now. It's like they won't feel anything, but it's if they're anxious already, it's the noise that really freaks them.
Yeah. Let's look at this case. This case, I think that summarize the main advantages of some technological aids. Microscope, how important is operating with microscope, ultrasonic devices, also the flap design. You will see this is a case in which I was suspecting of a vertical root fracture. So you will see like a combined flap. I had to raise the marginal tissue to explore very well the root on the mesial side, and I preserve the soft tissue on the distal side, trying to avoid damage to the papilla. And let's see how after a visual inspection with the microscope, I couldn't find the vertical root fracture. So I performed the apicoectomy with ultrasonic and apical cavity preparation with ultrasonic, and finally the obturation and grafting material placement. Sorry. grafting or not in cases like this, I think is controversial. In this case, I felt I needed. The lesion was big, and also we had an apicomarginal communication, so I felt it was better to do it.
Yeah.
Today, endodontic microsurgery must be considered as a predictable endodontic treatment to save natural teeth. I think it needs to be considered an endodontic treatment. It is. And finally, I want to invite you, everybody, to join us in the Facebook group. The Facebook is Endodontic Microsurgery. Now we are over 12,000 members, Daniel. Congrats.
Yeah, no, amazing. And it's and you've made a huge contribution to the group as well in like your amazing cases that you've joined. I think some people feel that because you've posted so many amazing cases, they feel intimidated. But it's like, I think it's not about, like, all your documentation and stuff is so good, but the whole purpose of the group is to really encourage people to consider incorporating microsurgery into their practice. And it's like, and if you feel you can't do it yourself, but to work with clinicians around you who can offer that to your patients, because at the end of the day, your own natural tooth is always going to be better than any prosthetic replacement, assuming that restorability and perio is good. We really have a lot of answers for a lot of the endodontic kind of problems that we're faced with now in practice.
Yes, we have in our hands a treatment with a high rate success. So let's do it. Let's do it.
More people doing it.
Learn. We can teach you.
Exactly. And part of what we discussed earlier on, so we're really excited that we're going to try and launch an international program between London and Colombia, where we can train people in how to get more proficient at endodontic microsurgery. So we can do demonstrations in London. We can do basic surgical skills where you learn how to raise a flap, you learn how to suture properly, you learn how to handle the soft tissues. And then with Paula in Colombia, you can get live patient, like you can do the surgery on patients yourself. So with supervision from Paolo and Filippo as well. So we're really excited. I'm personally really excited by that. I think I think it can be something that will be amazing and that we can kind of grow over time and really have an opportunity for people who are interested in developing their skills in microsurgery to have something. And then hopefully we can use the Facebook group as a support to kind of build their confidence over time before. I think what we've found personally in a lot of the kind of endo microsurgery courses we've done is that people know the theory and they know the basics, but then they fail to execute the actual practical part of it. So we really want to try and offer something that you're going to get hands-on experience, you're going to have mentors for it afterwards, and then we want you to go and actually do the treatments, line the cases up and do it.
Yes, you will see it's very funny.
Excellent.
You will really enjoy. Okay, Daniel, I don't know if there is.
I think we've reached the time. Thank you so much for an amazing presentation. I think.
Thank you.
We will, I think we'll finish now. If there's any immediate questions, we can answer now. Otherwise, we can get back on the microsurgery group with any kind of questions that we can finish on as well. But thank you so much for your time. That was amazing. Lovely to speak to you in person. And we will see you soon.
Okay. Bye, everybody.
Bye. Bye-bye.